Morning, Susan.
Good morning.
Are you hearing static?
A little bit.
Is there someone with a phone number 423? Yeah, there we go. I think that's better.
I think I just muted them.
Oh, great. Yeah, cool. Thanks. Okay, it looks like we have everyone. I'll call to order the Green Mountain Care Board's hearing of September 6, 2023. We have a number of agenda items. First, we're going to review the standard budget order conditions, and there's a potential vote noticed. After that, we're going to have deliberations and potential votes on a number of hospitals. I'm not sure if we'll get to all of them today. I think we'll go in the order that's presented on the agenda. So Southwestern, Northwestern, Brattleboro, Manascutney, North Country, Grace, Cottage, and Springfield. I'm not overly confident we'll get to the last few or that we'll get all the votes done, but we'll at least start the process today. And they'll be led by Director Lindberg and Mr. McCracken. So I'll turn it over to Director Lindberg and Mr. McCracken for the budget order conditions.
Thank you. So just a quick overview. We will review the standard hospital budget conditions, review some of the statutory factors that are part of the hospital budget review. That third item we're actually going to postpone till next week, but we'll talk about some of the inflationary indicators that we're looking at. And then we will see how many of these hospitals will have a chance to deliberate on today. So with that, I will turn it over to Mr. McCracken.
Great, thank you, Sarah, and board members. So we're coming back to what we're calling the standard budget conditions that we reviewed at our last meeting, and we had some input on and have made some changes. I wanted to start with just to note again what I said when I presented these last week, that these are effectively default conditions that would form the baseline of the conditions that the board would attach to hospital budgets. So for each budget approval, the board would include in its motion to include the standard budget conditions or any additions or changes to it. So the board could certainly add or modify any of these conditions for a particular hospital if the board decides that it would be appropriate based on the specifics of that hospital's situation and budget submission to do so. So with that note up front, the changes from what were reviewed last week, and I'm only going to highlight the changes here since I walked through all the conditions last week or at our last meeting. So the changes are highlighted. The first one is in condition D, which is that the hospital's expected commercial NPR based on its budget submission as adjusted by this order is a dollar amount that the GMCB can determine based on the budget submission. The hospital would then report its actual expected commercial NPR not later than we had previously said February 15th, but there were some comments that didn't provide sufficient time to see like a full month or enough time for the hospital to actually calculate its NPR, commercial NPR. So we moved that back to March 15th, recognizing that not all hospitals are the same. I also suggested some flexibility here, that the chair could specify a later date if that were necessary, given a hospital's contracting cycle with their commercial insurers or any other factors. So that was the first recommended. That was the first change from what was covered last week. Next slide, if you want, Sarah. I had no suggested changes on this set of conditions. These are generally reporting conditions for the hospitals, and fairly consistent with prior years. Next slide, Sarah. This is an additional condition that was raised by Board Member Holmes, and hopefully I've captured it here in a kind of appropriate way. So it's to say the hospital shall develop a system to be able to measure and report to the board the referral lag and the visit lag for each hospital-owned primary and specialty care practices, as well as the top 5 most frequent imaging procedures. And then referral lag and visit lag are defined here in the same way that they're defined in the board's FY24 guidance. The reporting for primary care and specialty care practices and top 5 most frequent imaging procedures is also the metric that was or the practices that were identified in the FY24 guidance. So really we're capturing that same wait times reporting requirement. And so the condition is for hospitals to have a system to be able to report those metrics. And then in the bullet down below, you'll see the hospitals would be required to report referral lag and visit lag for those practices and procedures once mid-year on April 30th, 2024, covering the periods of February and March 2024. And then, as the board might require in the FY25 hospital budget guidance. So, in other words, what would be required to be submitted with the hospital budget submission next July for FY25. So next slide, Sarah. And I didn't have any proposed changes in these final set of conditions. They're consistent with what we've had in prior years. And I didn't have any changes to those coming out of the last meeting. So with that brief recap and summary of the changes, I will turn it back to you, Mr. Chair, for board discussion, suggestions, changes, and there is some potential motion language here if the board decides it's ready to vote.
Thank you very much. I had one late addition that I wanted to make to the standard conditions, which relates to the population health management dollars earned by hospital-owned primary care. And the goal is to ensure that those dollars are being utilized for primary care. And I think the language, and we can discuss it if board members would like, but something along the lines of hospitals must account for and report back to the Green Mountain Care Board in their annual budgets the amount of population health management dollars earned by hospital-owned primary care, specify how those funds were used to support primary care, and describe the impact those funds had on improving primary care.
Could you just reread that one more time?
Yeah, I think the proposal I had in tried emailing it to Russ just a moment ago, but it would be hospitals must, in their annual budget, account for and report back to the Green Mountain Care Board the amount of population health management dollars earned by hospital-owned primary care, specify how those funds were used to support primary care, and describe the impact those funds had on improving primary care.
Can I ask you a couple questions?
Please.
Um, are you, do you mean to include the ACO? So there, what I'm trying to sort out is what we mean by what you mean by population health management fund. So that could be inclusive of the Blueprint for Health PMPMs that go to primary care, the ACO dollars that go to primary care, and if Blue Cross creates a primary care program, their dollars. Are you inclusive of all of those dollars? Were you looking to be more specific to just the ACO dollars?
Yeah, good question. I meant to be specific to the ACO dollars, given some of the concerns and lack of clarity that came out in our prior hearing about whether or not those dollars had been focused to primary care. I don't have the same concern as to the Blueprint dollars or any future insurer dollars because they haven't happened yet. But I would be open-minded to doing that in the future if we needed to.
Okay, so my suggestion would be it should be clear that we are specifically talking about population health management dollars received from OneCare Vermont, unless you also want to include the Medicare only ACOs in this as well.
Do you have thoughts either way on that?
I guess I would err on the side of including those ACOs since they are fairly new to Vermont and they don't have a big footprint, but it's my understanding we're going to have several of them coming in with budgets this fall. So I think just so that we're keeping all the ACOs in the state on a level playing field, it would make sense to understand understand that broadly. A hospital wouldn't necessarily, they won't be receiving it from more than one ACO potentially, unless they're participating in a Medicare only and then OneCare for the other programs.
Or not OneCare and one of the others as a possibility.
Right,
too.
right,
So yeah,
right.
no, I think that makes good. I think that makes good sense. We could change it to population health management dollars received from an ACO earned by hospital-owned primary care. Would that address it?
Yep. Yes, I think so. Yep.
And Robin, did you have more questions? I don't mean to interrupt, but
No, you go ahead.
thank you. Along the same lines of inclusivity, would it be possible for a hospital to receive population health management funds and use them in an appropriate way, but not to primary care? So I understand the concern the specific concern, Owen, that you raise with primary care funds that came out in a prior hearing. But do we want to be keeping track of how the population health management dollars are distributed overall? Perhaps somebody's distributing them in some other way, and that works great, or it fails miserably, and we'd like it to be more focused on primary care. Should we allow hospitals to describe what they're doing, even if it's outside of primary care? I guess that's my question.
I think I'd want to speak with the ACO team and the policy team a little bit more to understand if that's best in the ACO process or if it's something to be done in the hospital process and how
Okay.
that relates and if we're getting sufficient information on the ACO side. I tailored this proposal. And I apologize for doing it so late, but I tailored it to the specific issue that had arisen when we were doing the ACO review earlier this spring. So I don't know that I wouldn't be open-minded to that kind of suggestion, but I wanted to keep this pretty tailored.
Just a logistical note is the way that some of these funds, as I understand it, are transferred may not make it easy to isolate some of what I think you're trying to get at. Part of that is by design for an all-payer program. So I think, yeah, I think this could use some more workshopping and just figuring out if it makes sense as a standard budget condition or if there maybe is a other avenues to make sure that we're getting the information in a way that is meaningful.
Yeah, so I want to take away the opacity and ensure the money's going there. So if it's not easy to isolate, I want to see if there's a way that we can
To be clear,
assured it's
I don't want to be misunderstood. I'm sorry to interrupt, but like the population health payments from the what we think of as blueprint are lumped in with other things, and so yeah, so like the exact payment that you are, I think, trying to isolate may not currently be flowing, so we just have to be mindful of what that would mean in terms of lead time and burden and you know, the juice squeeze ratio.
I think to Tom's point, there could be dollars that are earned by the primary care that flow to, for example, a nutritionist who supports the primary care, but is not necessarily in the primary care budget. So which I think, Owen, to your point, would still support the primary care, but may not be quite as one-to-one as the language suggests. And I think you would want to capture that, right? So you'd want to make sure that we were capturing uses that support primary care, even if that is not located in the primary care office.
Yeah, I think that's right. And the intent of the latter clauses about specifying and then describing the impact is to get at that. And if the money is being intentionally allocated to support a nutritionist because it's beneficial to the primary care goals and effort, good, let's understand that. And then second, let's think about whether or not that is having the impact that we want. So I just want it to be intentional. If the money is going to support additional supplies at the hospital, you know, that might be more loosely connected to primary care. And so that's the intent of the latter clauses, is to be intentional about where those primary care dollars are going, and if they're supporting the reform policy effort that we have behind this.
I think the other sort of wrinkle we need to think through is not all hospitals own primary care, so it really should not be a standard condition. It should be only for those hospitals who own primary care. Or I guess we could, you know, make some additional edits to make it clear that if, you know, if it's appropriate, meaning they don't have primary care affiliated with their hospital, like for example, Rutland does not.
Right. The language that it would be to describe population health management dollar earned by hospital-owned primary care. So if you didn't have it, this condition wouldn't be triggered.
Got it. Yeah. Sorry, I like to see things in writing. It's hard for me to process it verbally.
Yeah, no, same. Yeah.
And how would that apply to like Gifford, which the hospital is owned by the FQHC, right? So it's not hospital-owned primary care, but it's hospital-affiliated primary care.
I don't know the dynamics of that specific situation and how the money would be earned and flow with an hospital owned by an FQHC.
I guess I go. That's a general question. Could a hospital earn population health management dollars without having primary care affiliated there? And if they could, wouldn't we want to understand also how they're using those dollars? Because we may learn something interesting about how they're using that money that could inform other places. So I understand the desire to have for this to be tight based on our history. But I'm just thinking, what do we really want to understand? And from my point of view, it's our population health dollars being used in a way that improves population health. And that may or may not be primary care. We had an instance in a prior meeting where we're not sure that primary care funds got to primary care. But if population health funds can be earned and spent and improvement results, I'd like to know about that. So a description of how the money, how they earned it, how much it is, where it gets distributed. I'm interested in removing and making that clearer.
Yeah, I think to me, this just feels like, you know, as was on the docket, is as we reevaluate the data model for how we're kind of collecting information from hospitals and tracking this funds flow. It is complicated. It's will take some time to unpack, but I think, yeah, I just have some concerns about, you know, just adding it without some more diligence. So I would maybe recommend we put a pin in this for now and offer a chance for the hospital finance team to consult with the ACO team and figure out what makes sense and come up with a proposal that we can provide in writing to take up next week.
I think that makes good sense.
But before I do that, are there any other, so I hear like trying to make sure that the dollar, understanding the funds flow, making sure that the return on that investment is operating the way we would expect, or in a way that we can measure more directly. Any other board member thoughts about what we're trying to measure or get at with such a condition? Okay, so I think that means probably not worth a vote today, and likely it won't be ready to vote on this on Friday, but hopefully Monday we can take this back up. All right, that could work for you, Russ?
Yeah, I think that's fine. I think that's fine. Before we move on, though, I would just open it up to any other board member comments, questions, concerns, or additions that we should work to incorporate as well.
I didn't have any others, although, you know, just for a preview, I would support all of the conditions we have in here, and as written, I would support it. And if there's a way to incorporate the suggested change that I had made today, I'd be supportive of looking at it and seeing if we can do it. But otherwise, I would approve all of these.
Yeah, I haven't said very much, but I would approve all of these as well as written, and I support the spirit of what Chair Foster is trying to achieve with the accountability on the funds flow. So look forward to kind of seeing what that language shakes out like, but support the spirit of it, to be sure.
I do as well. I just would comment quickly with regards to the amendment that Chair Foster suggested. I think that we talked about maybe two subtle differences, and I support both initiatives. I don't know if they're both appropriate for the hospital budget conditions, but one is an accounting of the dollars that were intended to go to primary care, and another one is, I think, getting to what Member Walsh suggested, which is thinking about how population health dollars are being used, coming up with a broader understanding of this, and trying to reflect on what's working and how we can help use our position to help share the successes that people are having, and maybe areas where they're not successful in use of this money. So that I almost feel like there's kind of almost two aims that have been brought up here. And I just think we need to think through if both of those are appropriate, or maybe I misunderstood what Member Walsh was suggesting, but I think it's actually a really potentially significantly beneficial understanding that we could have and share.
You didn't misunderstand, and you said it better. So thanks.
All right, I think with that, we can probably pivot to the next agenda item.
We can move on. When this comes back before, I'll also make clear in the motion language here that this applies to, as the standard budget conditions apply to any hospital budgets that were approved with the standard budget conditions before we made this vote. So just so that it all holds together correctly. But I just wanted to note that before we look at hospitals later.
Yep. Okay, you ready for the next slide?
I am. Thank you, Sarah. So I'm going to take a couple of minutes here and look at the board's criteria and principles for hospital budget review as set out in statute. And I know that you all have seen these before and you're familiar with them. So this is a review, but as we know, the board has a statute, has some statutory duties to review and establish hospital budgets consistent with the board's overriding obligations and healthcare reform principles. There's a hospital budget rule that gives us a more specific process. And then there's, of course, the FY24 guidance adopted under that rule. And all three of these are relevant and applicable for the board's hospital budget review and deliberation. This today is a look specifically at the hospital budget statutory factors. And starting here, just as a kind of a refresh, these are what the board said in the FY24 guidance around the statutory factors. I'm not going to reread it because it was in our guidance and it's a long thing, and I'm going to go through the statutes in the next slides. So we can go ahead to the next slide, Sarah. Under the board's hospital budget review statute in 9456, it instructs the board on what to review and what to consider in establishing the hospital budgets. That includes things like public comment, where it says that the board shall solicit public comment on all aspects of hospital costs and use and on individual budgets submitted by the hospitals. There are a number of other factors set out in the statute that the board goes through process-wise. Then the statute says that hospital budgets established under the section meet these 6 criteria, which are be consistent with HRAP, take into account national, regional, or in-state peer group norms according to indicators, ratios, and statistics established by the board, which we have set out in our guidance. Promote efficient and economic operation of the hospital, reflect the budget performance of prior years, include a finding that the analysis provided in a prior section, which is related to how the statute reflects a shift between commercial and public payers, and demonstrate that they support equal access to appropriate mental health care needs that meet standards of quality, access, and affordability equivalent to other components as part of an integrated holistic system of care. Then we move from, next slide, Sarah. Moving from the hospital budget statute, we have the board's sort of broad authority statute that says the board shall execute its duties consistent with the principles expressed in section 9371. Those duties include reviewing and establishing hospital budgets. Next slide, Sarah. These are the healthcare, the principles for healthcare in Vermont set out in 9371. I'll highlight a couple, but not to the exclusion of any others. So you see the first three here, that the state must ensure universal access and coverage for high quality medically necessary health services in Vermont. Systemic barriers such as cost must not prevent people from accessing necessary health care, and Vermonters must receive affordable and appropriate care at the appropriate time in the appropriate setting. Overall health care costs must be contained, and growth in health care spending in Vermont must balance the health needs of the population with the ability to pay for such care. And the healthcare system must be transparent in design, efficient in operation, accountable to the people it serves. And the state must ensure that public participation in the design, implementation, evaluation, and accountability mechanisms of the healthcare system. We can go to the next slide. We have here the importance of primary care and the importance of appropriate mental health care. I actually just included all of the factors in these slides, but like I said, I'm going to highlight just a couple. So Sarah, we can go on to the next one. So among the factors, we have that Vermont's healthcare system must include mechanisms for containing all system costs and eliminating unnecessary expenditures, including by reducing administrative costs, and by reducing costs that do not contribute to efficient, high-quality health services or improve health outcomes. Efforts to reduce overall healthcare costs should identify sources of excess cost growth. We can go to the next slide, Sarah. And then we have an important principle that Vermont's healthcare system must operate as a partnership between consumers, employers, healthcare professionals, hospitals, and the state and federal government. And the state government must ensure that the healthcare system satisfies the principles expressed in this section. In addition, and we go on to the next slide. In addition to the principles of healthcare in 9371, we have here the principles of the Green Mountain Care Board set out in section 9372, improving the health of the population, reducing the per capita rate of growth in expenditures for health services in Vermont across all payers, while ensuring that access to care and quality of care are not compromised, enhancing the patient and healthcare or professional experience of care, recruiting and retaining high quality healthcare professionals, and achieving administrative simplification in healthcare financing and delivery. So I wanted to provide this as the kind of statutory bedrock on which the board's hospital budget review and decisions are based. And I'm happy to take questions, although I would say if there are questions that solicit legal advice of counsel, the board may consider whether those questions are appropriate for an executive session.
I don't have any questions, but I really appreciate you providing that framework to remind us of the factors we should be considering. And I found that really valuable, so thank you.
I too don't have questions at this time, but I could see having questions at some point through this process on a specific hospital with a specific factor in here that I could see wanting advice on. So would that be an opportunity as time goes on?
Absolutely. If, as you know, this is a general non-hospital specific run through of the statute. If there are specific questions that come up, we can address them. If they are questions that call for advice of counsel, that can be appropriate in an executive session too. If and that's a determination the board could make at the time the question arises.
All right, anything else, or we good to move on? Okay. All right, wonderful. Thank you very much for that background. So just a quick, I wouldn't say quick, just as we think about inflation, which I don't know if you've heard has been uncharacteristically high in recent years. We're trying to there's different ways to think about inflation, how it affects the consumer, how it affects the prices that hospitals and other providers are forced to pay. And so just wanted to provide some grounding in some of the metrics that are available to project. So those that we have on a go forward basis versus those that we kind of have a historical perspective on. So one indicator that is used by our partners in Maryland to kind of think about their global budgeting process and the prices that providers face and is factored in to local conditions is what we call the Medicare market basket. It has several different iterations. But here we're looking at just the inpatient hospital portion. So the projected growth from fiscal year 22 to 24 for that measure is 7%. So again, that is really the cost basis as Medicare tries to look at it. And if you just look at how much of that they're projecting from 23 to 24, it's 3.1%. So a little bit more heavily loaded from 22 to 23 than from 23 to 24. But these values are still a bit higher than historical values. And if we look at median income, we were able to leverage some projections there. So the projected growth in Vermont's median household income is 8.6% from fiscal year 22 to 24, with that growth looking at 3.9% from fiscal year 23 to 24. The indicator we used in the guidance this year was related to the producer provider index, the PPI, which had to do with general medical and surgical hospitals. And when you look at kind of the longitudinal trend of 2-year growth rates, the median in that series was 5.8% growth over a 2-year period, but quite a wide confidence interval of 1.1 to 10.5%. So a lot of kind of noise in that data. When you think of consumer inflation, the CPI, Consumer Price Index, if you recall or have a chance to review the work done by the Cavett and Carr last year, the medical inflation tends to lag CPI, and that has to do with how sticky prices can be. So you negotiate the prices one time for the year and then come back to it. And so if you kind of shift the distribution, you'll see the trends are more aligned. So just some things to think about as we think about inflationary growth and how to grapple with that really difficult question in our proceedings. So next I'd like to just turn to the hospital budget decision tree. So in consultation with the board, there've been a few modifications to this, but in principle, the left side of the decision tree remains unchanged. Those are the hospitals we made decisions on last week, and those were Gifford and Rutland, who were able to submit a budget below the benchmark of 8.6% net patient revenue growth from fiscal year 22 actuals to the fiscal year 24 budgets. We've determined that those assumptions were reasonable and approved them as submitted. And now we're moving our attention to the other side of this decision tree. And so if and when these hospitals have come in above benchmark, submitting budgets in good faith that they determine they need, we will consider modifying them by evaluating and weighing the reasonableness of the budget assumptions, how each of the expense factors in the guidance compares with reference ranges, how expense growth compares with peers, how the request, particularly for rates, compares with the Medicare market basket and wage growth. Might want to consider some other inflationary indicators there. The factors and criteria set out in the guidance, and the factors, criteria, and principles set out in statute, which we just reviewed. So again, we're moving to this side of the decision tree. We have some kind of generic language if we get to any votes today that I can pull back up. But any questions about the modifications to the decision tree or the way we're going to kind of start tackling these deliberations? Okay. All right. So first up, I'm going to pull up a template. Oh man, okay. So are you able to see my screen? Okay, great. So what we have put together are some templates that essentially are designed to summarize the record to date. And so this is for Southwestern Vermont Medical Center. The top box looks at budgetary growth over time. So you can see for each fiscal year what the guidance was for NPR, what was submitted, and then this delta from the approved. So how much did the board's decision change what was submitted? So in the case of Southwest, you can see that longitudinally there haven't been modifications to the NPR in this time period. And you can see the submitted and approved commercial NPR. And finally, operating expenses. So how those have changed over time. And the last little bit is the change in charge. So as a reminder, the board historically has only approved changes in charge, which is the charge master. And so that's kind of the guiding star we have in looking at things longitudinally. And you can see what was submitted, if there was any changes from what was submitted. And then this last piece is the commercial weight of the improved increase. So that's looking at of what was approved in rate, looking at the prior year's share of gross patient revenue among commercial. So of that 2.9%, we looked at the fiscal year 17 gross payer revenue share of commercial to kind of weight that growth. And so you can see over time, pretty low weight of that improved increase among commercial for Southwest, with some jumps in the recent year, looking at 3.1% growth was approved last year, and if approved as submitted, an additional the overall growth would be 2.0 from 22 to 24. So a little bit of a reduction in the reliance on that rate. The next part of the template is looking at the actuals. So budgets are, a good guess, but never perfect. And so you can see that what the NPR has done over time for both in total and just the commercial portion of that NPR, as well as the change in operating expenses over time. And then we have here in the corner the gross patient revenue mix. So that's, remember, if everyone comes in and is charged the same amount, this is the share of that gross revenue that each payer would have. In Southwest's case, the traditional Medicare and Medicare Advantage are grouped. So back to the data model improvements we have in store, and see that that commercial payer mix for Southwest in 22 was 32% of their gross patient revenue. In looking through their expense factors, we can see that for labor, the growth from fiscal year 22 to 24 in per FTE compensation was 6.8%, which was the fourth lowest among Vermont hospitals. The median among Vermont hospitals was 4%. And we see the benchmark of 5.2% over time, with a range of 0.8% to 9.7%. Utilization growth at 1.6%, which was the 12th near the bottom of Vermont hospitals, the median at 7%, with a range of negative 5.5 to 4.2%, so within benchmark for both of those indicators. The pharmaceutical expenses are not broken out in the data reported to us today, but in the testimony given as part of the budget hearings, we found that Southwest's information came right from their group purchasing organization and was within the range of 2.3 to 21.6%. And cost inflation of 5% was toward the top, lower is better. So among the lowest in the state at 3, with the benchmark being 5.8%. So right around that kind of historical growth indicator. Just summarizing the financial position. So I think a lot of these results in recent years are pretty difficult. It's the financial challenges have been really toughest, I think, in fiscal year 22. We're seeing definite recovery in 23. But when we look at the values submitted in the fiscal year 24 budget, we see values that are very close to median in almost all cases. A reminder that when it comes to days cash on hand, a lot of that is held at the parent level for Southwest, so not the most meaningful indicator. So not going to lose any sleep over that 61 days. And seeing kind of the long-term debt to capitalization ratio dropping, and a fairly stable age of plant over time, which is close to the Vermont median. And then when we look at the ratio of administrative and general salaries to the clinical salaries from the cost report, Southwest had a result of 36%, which was 13th, so right near the bottom of Vermont hospitals. The percentile rank among its comparator groups was in the 38th percentile, so below the median, with that interquartile range being 37% to 53%. So right near that 25th percentile among the comparators. When we look at the average cost per Medicare discharge, they really stand out here at 8,451. That's the least, the lowest value that we have for that indicator. And among their peer group, they also were in the first percentile, so among the least costly based on that indicator. And then finally, probably the hardest thing to wrap our minds around is the relative cost and price. So we have inpatient and outpatient indicators here. So the commercial cost per discharge comes from the Burns data. So you can see that they are below the 25th percentile in fiscal year 18 for that commercial cost per discharge, right at it again in 19, below it in 20, below it in 21, and far below it in 22. Seeing costs that stable over time is notable. That indicates to me, because it is consistent for both inpatient and outpatient, and over time that is evidence that there's probably a lot of attention being paid to cost management. And when we look at the cost coverage, again, that's saying, so that's what Medicare says the allowable cost per discharge was. How much did they actually get paid? So they're at 105% in fiscal year 18, So the 75th percentile, and pretty consistently staying right near there through fiscal year 20. Staying relatively in the same place in fiscal year 21 and showing a little bit more cost coverage in fiscal year 22. Again, because they are low cost, some of the cost coverage is a testament to their management of those costs. And then for the standardized price, that comes from the RAND information that we saw. And so that's saying, here's all the money they got from commercial payers according to the all payer claims database. Let's divide that by a standard unit of cost. And we see that they are within that interquartile range for the inpatient. Turning our attention to outpatient, we see very similar trends in the commercial cost per discharge. So right at that 25th percentile among the hospitals in Vermont, and then the commercial cost coverage being on the other end of the box plot at 75th percentile. And again, right within the interquartile range on standardized price. The main reason that this hospital was over benchmark had to do with $5 million worth of investments to increase access to care that they wanted to provide in their community. So, the easiest way to get this hospital to be within benchmark would be to eliminate those enhancements. But I think they in the evidence I saw demonstrated some real thoughtfulness about what they were expanding, and did it in a way that they knew that the cost that they would be providing to patients would be an improvement from where they're getting care today. That is kind of what I wanted to present for you for this hospital. So interested in what other information would be helpful in deliberating on this hospital.
Thank you, Director Lindberg. I will, one procedural question, I think I got this right, but we'll do board member questions and comments. We'll have a potential vote. I'll read that, then we'll take public comment, and then if there needs to be a vote, there'll be a vote. Does that sound correct?
Is that right, Russ?
I can't hear you, Russ.
Okay, sorry, is that better? Okay.
Yeah.
I think what I heard was board member questions, comments, discussion. Any, I guess if going back to Dr. Merman's prior point, if there's a need for confidential executive session, and then a motion, public comment on the motion, and then a vote. I think that works, yeah.
Great, okay, thanks for confirming. Okay, I'll open it up to board members for any comment or question they may have.
Sarah, this is Tom. Could you bring back up the actual table?
Yes, eventually. Bear with me. Not such a boomer. All right. There you go.
So could you help me understand the in operating expenses, where it's in fiscal year 18, it's 4.7% and $7.2 million. Is that the change from prior year?
The percentages are changes from the prior year. The dollars are amounts certain. So those were the operating expenses. Yep.
Thank you. I was having trouble thinking of $7.2 million added.
Yeah, fair.
Okay, thank you for clarifying.
No problem.
That's it. Thanks.
Can I just pull one more clarification on that? So that's confusing to me, because if it goes from, say, 19, which is $7.2 million, and then 20,
oh yeah,
it goes
you're
up by
right.
1.5%.
Yeah, they're the amount change. I'm sorry, I misspoke. Yeah.
Okay.
Yeah.
Okay.
Yeah. So yeah, it is the amount of change. Sorry.
Sarah, could you remind me, I think I remember, but the investment in access improvement, can you describe that a little bit more for me again?
Yeah, sure. So investing in primary care finally staffed up since the pandemic. So really trying to enhance the productivity among primary care providers. And then they're also looking to provide more cardiology and oncology services locally, and really coming up with some neat ways of implementing some particularly oncology plans from you know, out of state providers, but able to administer those locally.
Right. Okay, thanks. I have nothing else. The only comment I would make is that, you know, a hospital that's containing costs and has high quality and is doing well, we want to see them making investments to do more of it. So I don't have any concerns with the budget as proposed. Maybe others do, but I'm okay with this one.
Yeah, I'll just jump in and say, you know, Southwest has always been a very well-managed hospital and really good stewards of Vermont's resources, evidenced, I would say, by their complete avoidance of travelers' costs. They figured out a way to avoid travelers' costs in an era when most other hospitals couldn't do that. Their cost per adjusted discharge are really low. Their employee costs have kept pace with the ECI growth. 5-star hospital, leapfrog A rating, you know, quality is really high, and they're managed to do that with low costs. So for me, this is a hospital that I think, you know, the budget was reasonable. The assumptions seemed reasonable to me, and we should applaud them for their cost containment efforts and the culture they've built there that allows them to retain employees and not rely on travelers. So I would support approving this budget.
I agree with everything you just said, Jess, and I just want to throw out a few things that I want to highlight that I do think we just sort of need to keep an eye on. On the Medicare cost report, they do have high admin costs, as Sarah mentioned, but they have this amazing ability to balance that with a low adjusted cost per discharge. So I think that, you know, it's something for us just to keep an eye on over time and make sure that relationship is maintained. The other thing I would like to point out is the recent partnership with Dartmouth-Hitchcock may have increased costs over time. And I think as a care board, we should keep an eye on what the cost of consolidation is to the providers, to Vermont and to that region. But I also am hopeful that the way they're doing it is actually going to lead to increased access and increased services for the community in Southwestern Vermont. And so just things to think about, things I'd like to keep an eye on in the future. But overall, you know, this budget is just over, you know, the recommended benchmark. The cost operating expenses managed to be contained. It's not asking for a large rate increase, especially given the climate we're in. So I support it.
Similarly, I think it's an organization to be applauded for the effort. But as with Dave's comment, that the admin to clinical ratio is not where we'd like to see it. But I wonder if they could help us unpack that number a bit further. If we could ask in our order to clarify that measure, how they calculate it, what goes into that measure. Every organization has some discretion in what they put in line 5 in the cost report. So helping us understand that, I think it's a type of organization to learn from. So I support it otherwise with that one request.
I support the budget as well and don't have anything further to add.
Great.
Although I'm happy to make the motion if that would be helpful.
If you'd like to, I think it sounds like there's consensus. And I will just point out, I recall the testimony being pretty specific as to the cost savings efforts that the affiliation was intended to drive. And, you know, that is something to make sure and follow through on and to hold accountable. But I think the intent was there, and they actually sounded like they had a pretty good plan. They were speaking about some of the redundancy they're going to make more efficient through the affiliation. So I'm looking forward to seeing that come to fruition. And it sounded like they had a good plan on that. So yeah, Member Lunch, if you want to make the motion, I think that'd be great.
Great. So before I do that, Sarah, I just want to make sure I have my numbers that I have in front of me correct. I think the MPR over the 2-year period is 8.96%. Would you prefer I round that up, or are we good with 8.96?
8.96 is fine.
Okay. And
Robin, before you get into the
Yes.
specifics of this, I just want to address, Tom had mentioned wanting to have as part of the budget order sort of an accountability of the admin to clinical ratio. I guess I just want to confirm, Tom, would you be okay if that was outside of the budget order? Do you feel that that should be part of the budget order and part of this motion?
I defer to our council and chair. I don't have a specific request for where it is. I think it would help us. So whatever's most appropriate.
I'll give my quick reaction if you go ahead, Russ.
Well, I was going to say the board could take either approach. Hospitals are generally pretty responsive to our requests to help understand and unpack data and cost reports. So I don't think you know it. Let me give you two responses. One is that, you know, we can and do ask for information from hospitals without having it as a specific called out as a specific condition, but we do have in the standard conditions that the board is considering a requirement that the hospital shall file all requested data and other information in a timely and accurate manner. And then separate from that, the board does have authority under statute to collect information from hospitals. So I think I'm inclined to say that we could accomplish that goal and get that information from the hospital without specifying that particular piece of it in the budget order conditions. But having said that, I could defer to the board if you thought it was important and wanted to call it out specifically as a particular condition.
I'll just give my view as one board member, which is this hospital's done really well at containment. So even if those admin numbers are not where we want, I know you know, there's some judgment here, and I feel the culture is very collaborative with Southwest and that they'll give us what we need and they're going to shoot us straight. Like, I just have that feeling that we don't need it here would be my reaction, I guess. I just trust that we'll get what we need.
Yeah, and they've already kind of helped us understand it from their perspective, and I think the work is kind of trying to integrate that learning across the different facilities.
That all sounds good to me.
Okay, so and Sarah, the change in charge that I had noted was 9.5%. Is that, am I correct?
So the charge will be from 23 to 24. So that is 6.6.
Oh, thank you. Okay. Here we go. I move that we approve Southwestern Medical Center's budget as submitted with a 8.96% increase from fiscal year 22 actuals to fiscal year 24 budgeted NPR FPP, a 6.6% charge increase from fiscal year 23 to 24, and that the budget be subject to the standard budget conditions that we will approve next week.
I'll second.
All those in favor, please say aye.
Aye.
Sorry.
Aye.
Thank
Did you want to take public
Oh.
comment?
Yes,
Oh,
sorry.
sorry. I'm sorry, I wrote it down too. I apologize. All right, well, thank you for the motion in the second, and I'll first turn to the healthcare advocate and then to public comment.
Thanks, Chair Foster. Nothing from us on this. And just to member Walsh's comment, the admin to clinical ratio, I think it could be something we think about with the guidance, maybe formalizing that more in FY25. But yeah, we support, as we said in our recommendations, we support it. Thank you.
Okay, and any public comment via the raise your hand function? Mr. D, and just for the record, I believe you're the CEO of Southwest. Please go ahead.
That's right. Thank you, Chair. And I just wanted to thank the board for their support. And please know we will respond quickly to any requests on any further breakdown information necessary on the administrative cost. And for Dave, your comments on the integration with Dartmouth-Hitchcock, certainly well taken, but clearly our strategy and vision is to help to make our operations more cost effective under that integration strategy. So we welcome a further review next year. Thank you.
Great, thank you for your comments. Any other public comment? Okay, and we had a second, so all those in favor, please say aye.
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 Aye, and the motion carries unanimously. Thank you very much, and I think we can move on.
All right. Moment while we shift gears. So next we'll be discussing Northwestern. Okay, so same template. Sorry, I just had the flash in my head for a second. So here we have Northwestern Medical Center. So you can see that over time, the board has made adjustments to Northwest's submitted budget. So there was a minus 1.3% adjustment in fiscal year 18 and a minus 4% adjustment downward in fiscal year 21. Of note, that budget already came in as a negative, and the board further adjusted that downward. Also of note, they were one of the only hospitals that submitted a budget within benchmark last year. But if we look at the 2-year growth rate at 10.3%, they are a smidge above the guidance of 8.6. Looking at their commercial NPR over time, the board actually made an upward adjustment in 18 that had to do with some late breaking information in the budget process that year. But there was a downward adjustment again in fiscal year 21 of negative 7.7% in the approved budget. So that's where some of that adjustment came from. And then some adjustment after the board's decision related to they took it upon themselves when the final Medicare rule was higher than the proposed to give themselves a bit of a haircut to account for that. So operating expenses were adjusted a little bit upward in fiscal year 20. If memory serves, that was mostly COVID related and giving kind of more room for some of the unexpected expenses that hospitals were facing that year. And then looking at the rate increases that were submitted over time, you can see again in the years where the NPR was adjusted, those rates were adjusted downward to the tune of -2.5% in fiscal year 18 and a -8.1% adjustment in fiscal year 21. You can see that the commercial weight of the increases was a little bit higher in fiscal year 21, but generally was, within the range of about 2 to 4%. If approved as submitted, that change in charge would be 6.0 for the 2 years, so a little bit backloaded for the 2 years. But only about half of that is kind of being reliant on the commercial payer mix. Looking at their actuals over time, again, so these are got that clear changes in rates and amount of money. So seeing that their operating expense growth had been north of 5% up until 2020, but has been below, close 3 or almost or near that or under since. So pretty impressive management of the operating expenses. Also, seeing a lot of volatility in the pandemic and seeing that recovery starting to kick in fiscal year 23. Have a relatively higher proportion of commercial payers in their gross payer mix. And again, the one that's tricky here is that Medicare Advantage actually is in this bucket for them. So that number is a bit deceptive and it likely is inflating some of these estimates a bit. So just note that. So the labor expenses, they were among the, most impressive in terms of, decrease in the per FTE compensation. Some of that has to do with the restructuring they're doing, but certainly within benchmark. I'm below the median among Vermont hospitals. Some modest changes to utilization related to places that they're trying to address access issues. And again, don't break out the pharmaceutical expenditures in the adaptive information, but testimony showed that they were comfortably within that range. And that was based upon the group purchasing values that they have and cost inflation, again, very close to Southwest. So seeing that 5%, which is very in line with historical values, if a bit above the Vermont median for this year. So yeah, looking for some recovery, but seeing that most of these values, again, are very close to the Vermont medians. Days cash on hand are a bit higher than the median. I think that as hospitals contend with the volatility in their revenue nationally, we're seeing kind of a more interest in trying to retain that cash and kind of protect the ability to borrow when needed, especially for deferred improvements. Debt service coverage ratio below the median, but not necessarily a lot more volatility in this just due to kind of market conditions and long-term to debt capitalization ratio, very close to the state median, and the age of plant looking pretty consistent over this time period. They were near the bottom of at 27% of that ratio of admin in general to clinical. Among their comparators, they were the 33rd percentile, which is below the 25th percentile. So, relatively lower, more investment in clinical information. Clinical salaries, and then the CMI per adjusted discharge. This is one that Stephanie Bro and I have been kind of noodling about what might be going on here, but just trying to learn more about that indicator as it is manifesting at Northwest, but near the number 9, so getting towards a little bit above the midpoint among Vermont hospitals and among their comparators at the 96th percentile, so pretty close to that 75th percentile, or I'm sorry, a little bit north, a little bit higher than the 75th percentile among their comparators. And then when we look at the commercial cost per discharge, we see that they over time are kind of relatively stable near the 75th percentile in cost, but also see this cost coverage. So they are not getting the costs covered, the Medicare allowable costs covered by the commercial rate. Some of that in recent years has, improved a little bit, but seeing that at 76% is not necessarily common for commercial cost coverage. And looking at their standardized price, they were below the 25th percentile on inpatient. On the outpatient side, we see a stable trend, but here they're towards the 25th percentile over time, with the cost coverage being more favorable, but declining in, getting back to around that 200% of the cost. So the Medicare allowable cost being at the 25th percentile, they're able to cover about 200% of that cost. And seeing here, they're right within the interquartile range on the standardized price. So to me, that's showing kind of relatively low commercial reimbursement compared to peers, which, putting their commercial request into context, which was, I want to make sure I say this correctly. Oh, where are you? There you are at 6%. So of that 6% rate increase, expecting 4.5% from the commercial payers. So that again is kind of the summary. This one seemed really clear. They've demonstrated a lot of work to improve the quality and seem to be tackling that head on. Received some late breaking news that they will in fact participate in all 3 ACO programs, which I think is a really big deal to the communities operating up in that area. So just a shout out for that from staff, or from how I see it anyway. So that was what I wanted to present today related to this submission. Any questions, comments, concerns that would help the board in this decision?
So, Sarah, could you keep that document up and actually pan back up again? I just have one question for you. Let's see. So on commercial NPR submitted and changed and approved, I just want to understand I get this field correctly. So say in FY21 where the submitted was 11.4%. And the changed approved is negative 7.7%.
So the board adjusted that 11.4 down by 7.7 percentage points.
Okay, so it's still a positive. It wasn't they were given a negative rate, but the board adjusted the 11.4 down by 7.7. So it's still okay.
Yeah.
This is my one question on this. I guess I'll just start otherwise. So I think Northwest is coming in very slightly above the NPR FPP target, and I think largely driven by some increases in utilization that I think is probably appropriate for the region. I'm very supportive of their budget. I mean, I think the admin to clinical ratio that gets flagged out on the cost report is something to think about. And again, I think similar to what Tom suggested for Southwestern, that we could speak with Northwest to discuss it, but I also think that that's balanced by low inpatient prices and prior low increases. So in spite of having this one data point just seems aberrant from the rest of the trend. So I'm supportive of this approving this budget in full.
Same. I have the same response as I did with Southwest. I'd like to understand that ratio better at this facility. And if you could scroll down a little bit, please, to the cost per discharge table. Yeah, I'd like to understand this a little better too at this facility. There's it doesn't make sense with the rest of the information and data points that we have. I think it's a strong submission, good trends. But I'd like more information from them to help understand that number.
Yeah, I don't want to speak for Stephanie, but she's also very eager to get to the bottom of it. So
Yep. Great. Yeah, happy to work with them to try to figure that out, because it's yeah, my suspicion is there's just something yeah, it'll be good to learn more with them.
I don't have anything to add. I did have one question to make sure that I caught it correctly, Sarah, if you go up a little bit on this. I think you were saying that for Northwest, that the Medicare Advantage is reported in the commercial, right? So even though the chart on the right says there's 0 Medicare Advantage, that's because it's reported in commercial. Am I getting that correctly?
that's correct. Yeah, and they're in the process of starting to break that out in their own systems. I think everyone knows that that's an important revenue stream to isolate. So
Great. Yeah. Understood. Okay, thank you.
I don't have anything to add. I support the budget. With Member Walsh, I'm very interested in understanding more about the cost per adjusted discharge and why it's so high, but I suspect we'll learn more as this goes on. And hopefully we'll either figure out if there's an anomaly in the data, or I suspect, given the, the efforts underway at Northwestern around productivity and around cost containment already happening, that number will come down. So I support the budget as it was submitted.
I also support the budget.
I'm happy to make a motion if we're ready for that.
I think we are.
Okay. And before I do that, I was remiss in saying I did want to commend Northwestern on their equity efforts. They've been a real leader in that area, and we have some of their folks from Quality and Equity participating in the global budget tag, and they've been very helpful in thinking about those aspects. So I'll move that we approve Northwestern Medical Center's budget. And Sarah, if you could move to the motion language, please. Just so I get it right. I can try to do it. Try to do it. I'm seeing standard budget conditions.
Okay.
Great. I got it. Thank you. Move to approve Northwestern's budget as submitted with a 10.32% increase from fiscal year 22 actual to fiscal year 24 budgeted NPR FPP, taking into account the provider transfer included in their budget, with an increase of 6% in charges from fiscal year 23 to 24, and subject to the standard budget conditions. Please correct me if I messed that up, but
I believe that's correct. Just, for the record, that is accounting for the provider transfer. So
yes,
that is kind of the,
we typically do need to approve have approved the provider transfer impact on the NPR, which is why I included that in there.
Thank you. Yeah.
Yep. All right, that's my motion.
All right, I will second it, and then I will turn to the healthcare advocate.
Sorry, it took me a second. Nothing from us. We support it. Thank you.
And is there any public comment? Ms. Rialt?
Hi, I just want to thank you guys for supporting Northwestern, and I want to turn it over to Peter Wright as well, because I know he wanted to say a few words, but really appreciate the collaboration with Sarah and her team, and very, very happy to continue working with you on the admin ratio and the cost per discharge ratio, because I agree there's something going on there, and I really, really, really want to know what it is. So we will absolutely get to the bottom of that.
Great, thank you. And Just for the record, I believe you're both associated with the hospital, but Mr. Wright, please go ahead.
Thank you, Chair Foster. Yeah, Stephanie's our Chief Financial Officer. I definitely want to thank the spirit of cooperation. We're very, very willing to come to the table to better understand those numbers. As you recognize, and we appreciate, very diligent about keeping our costs under control while moving forward hospital quality and safety, and making sure we do that in an environment that supports equity and equality. So really appreciate you taking the time to mention those things we're working really hard on, and appreciate our partnership with the board. And you tell us when you can meet and we'll be there. So thank you.
Great, thanks. I don't see any other public comment. I think Mr. Wright's point is right. I mean, when you can do what they're doing in an economic and efficient way, it's a benefit for our system. And so I think that's why it looks like we have unanimous support, and we'll take our vote. All board members in favor of the motion, please say aye.
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 Aye. Motion carries unanimously. Thank you. Director Lindberg, I want to take just a 3-minute break if we can, and then we'll just come back and proceed. So we'll come back, we'll make it 5. We'll come back at 11 a.m.
All right, thanks for your generosity.
Let's go crazy. Thanks. Okay, it looks like everyone's here, so we can resume. I'll turn it back to Director Lindberg.
Okay, so the next hospital that we will look at is Brattleboro Memorial Hospital. All right, hopefully that's coming through for you. So a few important differences about Brattleboro Memorial Hospital is they have some Medicare designations as a Medicare dependent and low volume hospital that affects the reimbursements they get through Medicare. So that is kind of the main driver of the NPR that we've seen in the submitted budget. So we do see that over time, and I apologize, I didn't flag these, but over time we have seen some downward adjustments to the submitted NPR for Brattleboro. So took 1.7 off of the 5% that was submitted in fiscal year 18, took 1.5% off in 19. 2.2% off in 20, and in 22 there was a downward adjustment of 2.7%. So quite a few adjustments, but were approved at the 13.3% last year for the 2-year total of 19.9. So a lot of the 2-year growth is front loaded in the current fiscal year. Seeing a lot of change in the commercial NPR over time. So again, some of those adjustments trickled down to the commercial NPR over time, seeing, substantial growth in 23. I'd like to point out that that is largely driven by utilization. So they were hit pretty hard with the Omicron variant in fiscal year 22 and had especially low utilization rates. So I just don't want anyone to see that as pure price because it's largely driven by utilization. Operating expense growth, so again, some downward adjustments over time, but aside from fiscal year 20 and 23, below 5% in the submissions. And then looking at that change in charge, there were some downward adjustments. But again, given the mix of the commercial payer in the gross revenue, we see that by and large, the contribution that's making to their bottom line is pretty minimal, with 23 being an exception at the 5.2%. But the ask for the current fiscal year would be a 1.5% change in charge, which is about 0.5% when you weight that by the commercial payer mix. So just a lot of that approval happened last year. You can see over time that the operating results here, are pretty spotty, a lot of volatility. That's mostly because of the small numbers, but seeing that the operating expense growth has been pretty well managed, fiscal year 20 being the exception due to some COVID related stuff and obviously the inflationary growth that we've seen in recent years. Working on getting kind of the most up-to-date information for them. So don't have that populated for you today. And the commercial case mix, so again, not seeing that breakout for MA, so that's appearing in the Medicare, a traditional Medicare bucket for now, and that commercial gross contribution to the revenue is at 36%. For expense growth factors, so the labor per FTE compensation growth was at 10%, so the third ranked hospital in Vermont. Just above the benchmark. So seeing that they're kind of trying to invest in more resources locally, we heard in their testimony, and move away from travelers and bring some of that cost in-house. Utilization again, so this is a testament to how low the utilization was relatively in 22. So just a huge increase in utilization, just again, mostly due to the Omicron variant and some other disruptions in fiscal year 22. Another crazy outcome for the pharmaceutical expense. So that's, usually you have a patient that had a very high cost pharmaceutical that moved on. So just a very volatile number in this case. And the cost inflation at 6% is right near that benchmark, and number 2 ranked among Vermont hospitals. The operating margin submitted is very modest at 0.7%, so definitely not trying to grow too fast or to too high a margin. Still trying to recover in terms of their cash position. Total margin also quite far below what we're seeing in the Vermont median. And that age of plant is pretty high compared to other Vermont hospitals at 25 years. So know that there's probably some additional capital improvements that are going to be happening. And so for the admin ratio of administrative and general salaries to clinical salaries, they were the third lowest at 16.8%, right at the median compared to their comparator groups. Or the 54th percentile, which the way the data is very skewed, so that is also the 75th percentile. And then the cost per discharge is also quite low at 9,928. So seeing they happen to be right at that same relative position and near the 25th percentile in that distribution. And then finally, so when we look at the cost per commercial cost per discharge from the Burns data, we see that they were right within the interquartile range in fiscal year 18, but only had 97% of those costs covered. Their cost was relatively lower in fiscal year 19, below the 25th percentile. So that drove better cost coverage. That trend has kind of continued since, and seeing an improvement on the cost coverage, but not seeing an improvement in cost. So one reason you would see that trend is cost management improving. And then see a very almost identical pattern on the outpatient side, though in recent years, seeing that creep up a little bit. I think that's more as care shifts from the inpatient to outpatient setting, and seeing that their cost coverage is relatively high for commercial payers for outpatient procedures, and their standardized prices within the interquartile range. So yeah, I think this one's a little bit funky in that the NPR growth is the highest that we saw, but the commercial rate increase is the lowest. So kind of an odd mix to see. I don't think we see that pattern every day. So I think there's maybe a lot of questions here. So want to understand what will help you make your decision on this this particular submission.
I have one quick one, Sarah, before we turn to the other board members, but you go to the age of plant one, there's just a number that jumped out at me. So in 22 actual was 15.7, but then it jumped up to 16, and then 23 year to date, 26. And then 24 submitted 25. I just didn't quite understand how those ages can fluctuate so drastically.
Yeah, let's look into that, because yeah, that jumped out at me too, and I didn't get a chance to go back to the record on that one. So I can take that as homework.
Okay. I'll turn to the other board members.
So Sarah, on the utilization and the NPR growth, so when I look at the profit and loss statement that was in this submission, it looks to me like from at least at that time, 23 budget was 105, 484, 860. The projection at that point was 106, 227, 721. And then the submission was for 111, 164, 182. And that the fiscal year 23 to 24 budget to budget was 5.4%. So it seems like the growth from 23 to 24, it would be a little bit less than that from projected to budget.
Exactly. Yeah.
Just that just helped. I just thought I'd say that out loud because that helped me kind of follow the 22 actuals, which are skewed because of the COVID issues that they had with their staffing early in 22. So that's all. I just wanted to make sure I wanted to say that out loud and just make sure that still seemed accurate.
Yeah, no, that's a really good way to kind of frame it. Like, yeah, this one really is a little bit not like the others in a lot of ways.
Hey Russ, I have some questions for you regarding this budget that I think relate to matters that are confidential, and I'm trying to figure out if there's a way we could speak about them in an executive session. So I was interested in at some point in here making a motion to enter executive session to discuss this. If that should be now, Owen, or if it should be after further deliberation, I'm not sure.
Let's finish board member questions and comment. Actually, let's finish public comment as well. And I think then maybe do executive session if that's okay with you.
Mm-hmm.
Okay. Do you have anything else aside from the legal advice, Dave?
I'm going to hold off for now. Yeah.
Okay.
Any other homework for the team here? Okay, so I think the board looks set unless Chair Foster, you have anything for us?
No. Why don't we put up the motion? I don't think we're going to vote on this one today, but we might as well put up the motion and just see the language, and then we can take public comment. Okay. Actually, you know what? I'm sorry. I should wait until we actually have what the motion is before I take public comment. So why don't we turn to the potential executive session? And I think we need two motions to do that. So I'll move first and move. We find that premature general public knowledge regarding legal advice of counsel at the board regarding the board's consideration of Brattleboro's budget would clearly place the board at a substantial disadvantage in any appeal or other challenge that may arise out of the board's decisions.
Second.
All those in favor of the motion?
Aye.
Aye.
Aye. The first motion carries. The second motion is that I move that we enter into executive session to consider confidential attorney-client communications regarding the board's consideration of Brattleboro's budget under the provisions of Title I, Section 313A1F of the Vermont statutes. Attendance at the executive session will be the board members and the board's legal team, executive director, and staff working on hospital budgets.
Second.
All those in favor?
Aye.
Aye.
Aye. And the vote carries unanimously. Ms. Lajes, do we have an executive session set up already?
We
Just
just
came
emailed
through.
it to you.
Great, great, thank you. Okay, we'll adjourn this and the board will go into executive session, and I don't know how long it'll take, but 15 minutes perhaps. Okay, thanks. We'll adjourn and go to executive session.
Okay, we will reconvene our hearing, but it will be brief because we are going to, I'm going to move to seek to adjourn because of a meeting I have to get to, and I think Robin has to get to. So we'll take up Brattleboro and the other hospitals on Friday. And so is there a motion to adjourn?
So moved.
Second.
All those in favor, please say aye.
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 Aye. We're adjourned, and we'll see you on Friday. Thank you.